Hello, everyone, and welcome to today's webinar. My name is Daniela Labate, and I work for NIAPRIS, and we are one of the Adult MCTAC Plus partners. And on behalf of all of our partners, I'd like to thank you for joining us today for the second webinar in our Solutions That Work series, Access and Engagement in the Value Equation. So just some quick housekeeping before we dive into today's presentation. The webinar is being recorded, and you can access that recording usually in about 48 hours on the CTAC website. We have set some time aside at the end of the webinar for questions, so we do encourage you to use the chat box feature to type in all of your questions, and please chat your questions to all panelists so that we can all see them. And just as a reminder, the information you receive today is current as of today's date. All right, so here's our MCTAC and CTAC partner slide. And here is the Adult MCTAC Plus partner slide. And as MCTAC Plus partners, we work together to provide individualized and hands-on training and technical assistance to behavioral health providers throughout New York State on the successful transition to Medicaid managed care. And as I said earlier, this is the second in our Solutions That Work series. The third webinar will focus on integrating primary and behavioral health, and that's going to take place on November 29th at noon. So please go to the ctac.org website and register for that offering. Today's presenters are from Astor Services for Children and Families and People, Inc. And before I pass the ball over to our presenters, I just want to take a minute to introduce them to you. Renee Fillette is the Chief Operating Officer at Astor Services for Children and Families. Astor provides education, child welfare, and a full range of children's behavioral health services to over 8,000 youth throughout the Bronx and upstate New York. And Renee previously served as the Executive Director of Grace Smith House, a domestic violence agency in the Hudson Valley. And prior to that, she founded and directed St. John Bosco Child and Family Services, a specialized child welfare agency with group homes for complex children in the foster care system. And Steve Michio is the CEO of Projects to Empower and Organize the Psychiatrically Labeled, or People, Inc., which is located in Poughkeepsie. People is a peer-operated advocacy and service organization that serves individuals throughout New York State. And Steve is one of the nation's foremost experts in establishing and managing alternative peer-operated crisis diversion, respite, and stabilization services. And he's assisted in the creation of various complementary peer services in New York, across the U.S., and Europe. And finally, I want to introduce you to Eve Addis. Eve will be the moderator for our panel discussion today. He's worked in the behavioral health field for over 20 years in both residential and outpatient services, and he's quite well versed in the areas of access and engagement. So just to take a minute to thank our presenters, Renee and Steve, for taking part in today's webinar. And with that, I am going to turn it over to Renee so that she can tell us a little bit about Astor Services for Children and Families and what that organization is doing in the area of access and engagement. So, Renee, I am officially passing the ball over to you. And I think your phone is muted. There you go.
I think so. Can you hear me now?
Yep, you're all set.
Can you hear me now? Thank you so much for that. So at Astor, as you saw, we're a fairly large and complex organization. We are geographically spread, so we work in the Bronx and throughout the Hudson Valley region. And we provide a full range of services for children ages 0 to 21. And we work in the areas of care management. We have a very large care management program in the city and upstate. In education, we operate several schools. In residential services, so our residential is both a child welfare group of services, but also we have a residential treatment facility, which is the highest level of residential care before a hospitalization. We have a full range of crisis services, and that is 24 hours, 7 days a week, and we work with other partners to provide some of those services, but those are primarily the home and community-based services. And we, of course, operate our outpatient clinics. And the vast majority of the 8,000 children that we serve are actually in those outpatient clinics. Roughly about 6,000 kids are in that system. And that is, I just want to mention before I start going through some of the slides, that entire system has gone through a massive transformation, where it was an economic loss leader for the agency by a lot, not just by a little. And we are now in a surplus position with that entire system of care. And more importantly, we transitioned from receiving many complaints about our availability, access, there just aren't enough behavioral health services, complaints about our staff turnover, and we've transitioned into a very, very healthy place with demonstrable outcomes. So, and I just want to make an overarching comment about that for us has been all about data analytics, having really good analytics to know what we're doing and how we're doing it. So I'm just going to move through some of the slides fairly quickly to talk specifically about access and engagement, because those are the two components to have contributed to such success for us. So one of the first things that we did was to really acknowledge the power of the front office staff, and we trained them to be customer service representatives. We trained them in mental health first aid. We gave them lots of skills to be able to answer very detailed questions for people who are walking into our clinics, and to be able to also mitigate crisis as they're happening in front of them. So we acknowledge really the power of that first encounter and wanted to make sure that our staff was able to handle it in an expert way. And then we also acknowledge that we ask people to fill out a ton of paperwork, and it's very off-putting, confusing, and we are very happy that our clinicians have really stepped up to help facilitate that process and work through that. Then we moved into an open access environment, and it really wasn't good enough the first time we did it, because even though we moved into being available during the daytime really wasn't when most people wanted us to be available. So we expanded hours at least until 5 o'clock. We're going to be moving into some evening hours, and we're able to meet clients' needs. And when they come in actually for those open access hours, they're typically seen within 30 minutes. So that essentially means almost anyone walking into any of our clinics, whether or not they have an appointment, can typically be seen within 30 minutes. Which slide are we on? The mechanics I mentioned already briefly, that there's a significant amount of paperwork. We really walk through that paperwork with people so that they're not overburdened by that. And the next slide. And the way we engage people who are coming to us for this open access, or folks who are coming into crisis, is we make sure that even if a therapist isn't really right there to see them in that moment, that we have wrapped ourselves around them in terms of all of our home and community-based services, our health homes, our waiver, our crisis stabilization services. So if they're not able to complete an intake assessment at that time, we're definitely able to send them out the door with an abundance of services so that they're leaving with more than they walked in the door with. And then also, if a hospitalization is really necessary for one of our children, we do everything we can to help them avoid the emergency department. So we do everything we can to facilitate a direct admission, which in our neck of the woods, I don't know how it is for our listeners, but in our neck of the woods, an emergency department visit can be anything from 10 hours to a couple of days just trying to get a placement. So that's another way that we really work to move folks forward. And I just want to get to the slide about access and engagement with the dashboard. So all of this is managed for us using one supreme dashboard, I should say. It feeds all the way up to the C-suite executives at the organization. It can be drilled down to individual clinicians. And we pay a lot of attention to how satisfied clients are, how long they have to wait to be seen. We pay attention to how many people go through an intake appointment and then follow up with engaging with therapy, and our rate of compliance there, our rate of admission there is actually 96% in one county and 97% in another county, so we have very high engagement rates. We monitor all follow-up appointments, and we really pay a lot of attention to children who we identify as being high-risk children. And so all of this really we can demonstrate through our data, and we look at it weekly to make sure that we continue on the positive trend. And we are also randomly speaking with clients individually and parents individually just to make sure that our quantitative data is matching up in a qualitative way. So I'm being told that that is sort of the end of my. No, there's a little bit more time. Okay. No, I think I'm pretty good. I'm going to wait for Eve's panel discussion.
Okay, great. All right. Hi, everyone. This is Steve Michio from People. And People is a peer-run organization where we've gotten involved in moving beyond just advocacy into providing services. So we do a lot of supported housing, housing first, HUD housing. We have recovery centers, mobile recovery center teams. We do a lot of work in crisis services. We run 4 respites ourselves. We have peers in the emergency departments, as well as peers in all the different partner provider agencies to help people navigate through their care. So just to get to the slides, we don't like wait times for people. So one of our partners, or many of our partners that we worked with at the Stabilization Center in Dutchess County, New York, is an instant admission, instant access center that is a wonderful place for people to go when they're in crisis to avoid emergency department usage. Everything in our services at the organization is immediate access, excluding housing, unfortunately, because they have to go through the SPOA process or some kind of assessment process before they get into housing. But all of our other services that we provide are instant access. Some of the work we've done, and we'll probably talk more about this from the panel, is the community-based asset development process. Is how do you get a community to work together, especially with the Stabilization Center, so that people are served within 23 hours within community provider agencies. And so we'll probably talk more in depth on that as we get into that panel discussion. There's always barriers. What I find in our world, and not just in our behavioral health world, but in our world itself, there's getting cooperation from other providers, from other organizations can be a challenge. And finding leadership that has the will to make these changes is a challenge at times. Most of the times it's not, but it has been a challenge at times. Communication breakdown. I often talk about our provider meetings when we all sit together in our provider meetings and talk about how well we work together, and how I sit there and say, well, we really don't work well together. We just come together for these meetings and are polite to each other, and then we go on to back to our silos and do our work. Fortunately, a lot of that has changed with the Affordable Care Act and with the Medicaid restructuring, so that we do actually start to work together and work well together. But we go the extra step, I think, especially in Dutchess County, where we've really tried to develop a better integrated system of care within the county. So how we manage first successful engagement is we practice trauma-informed service delivery. That's really important for us to understand that everyone we serve, everyone we work with has probably been traumatized to some degree. And when you take a trauma approach to care and to engagement, you get better outcomes, different outcomes, more information, better information, and you help people kind of figure out how they need to talk to their provider and help them with their own scripts on how they can talk to their provider better in more of a trauma-informed environment. Transparency in the engagement is important. Telling people what your expectations are of them as a person getting services, but then also as a provider what they should expect from us is very helpful and important. Lived experience is our secret sauce in our organization because all of our staff in the organization have a lived experience in behavioral health, whether that's addiction or mental health. And so having that mutuality is really helpful in building a relationship with folks. The design and practice of customer relations is ongoing. We're always looking at our customer relations through surveys, through self-reports, through conversations, through motivational interviewing to find out, are we doing the right work and providing the right service for you as an individual? So it's very person-centered. Improving the environmental design is real important. If you came to one of our respites or any of the respites that we've helped open across the country and internationally, they're very comfortable, safe environments for people to go and work, to work on their issues. So we work really hard on our environmental design. And then creating a value-based system around recovery, not around illness. So we take that, instead of focusing on the illness, we focus on the wellness of an individual. So it's a very strength-based approach for folks. The mechanics of responding to requests for immediate support is, like I mentioned, the Stabilization Center in Dutchess County. Our respites are accessible within an hour of it, for admission. Self-reporting and hearing a person as a credible reporter, because a lot of times people don't feel that they are a credible reporter if they're sitting in an emergency department or with another provider or therapist or whatever. They don't feel that they're being respected as a credible reporter, and we really try to emphasize that we do look at everyone as credible reporters. Building a system of immediate care community services is real vital, and that's part of that asset-based community development process that we've gone through. So the impact strategies that we've had are, we've seen a 12% reduction. This is a preliminary outcome, but a 12% reduction in ER visits for the people that come to the Stabilization Center. There's been a 98% success avoiding ER visits from respites in a 12-month look back, which is, I think, a pretty successful engagement and outcome. Warm handoffs or immediate engagement, we walk people to their services or transport them to their services. We don't rely on just the referral system because referrals don't often work well. And we've improved communication among community providers to ensure there is successful engagement. So like I said, embedding our staff in those environments has been really helpful because we get the instant outcome of knowing whether that engagement was successful or not. For that individual. So I think now it goes to Eve to have a panel conversation, and I'm passing it on to you, Eve.
Okay, thank you both for all of that. It's a lot to digest. What I would like to do is get into some more specifics. So. I'm going to, based on what you've already told us, I'm going to ask you each specific questions and then ask questions that either of you can respond to. So let me ask this, because I'm actually thinking that the audience is probably very interested, Steve, in the community-based asset development process. And, you've alluded to it a couple of times in your brief presentation. And I think I get it, but can you kind of explain what that is in terms of if somebody wanted to replicate that, because it certainly sounds impressive. Can you go through a little bit of how that would happen, that might happen?
Yeah, so there's different models that exist on how do you get a community on the same page and to move in the same direction together and implement that change or that paradigm shift that you want to create. And we used appreciative inquiry, which is a process of having a couple facilitators, and you can bring in as many as 5,000 people for something like that. Dutchess County, I think the first one we did was a couple hundred people, and then the second one was I think around 50 participants, and they're from all walks. You know, we had people that were homeless, people in services themselves, provider agencies, chambers of commerce, county government was there. So we tried to include everybody in that process. And what they do is they ask questions, and then they break the groups of people up into smaller groups, and they have to answer specific questions about, you know, what has been their experience, what would they do differently. So you get some really good ideas that come from, you know, outside the box sometimes. The good thing about that, the process is that you have the leadership in the room, and these are the decision makers to say, yes, we'll do this, or no, we won't do this. So you're avoiding the process, the bureaucracy, and the minutia around, you know, how do we get from here to there? Because when you have the decision makers in the room, it makes a real big difference. And once you're done with that process, you actually have an implementation or strategic plan that you can use to move into building what you want to build. And from that, we built a mobile crisis team in the county. We built improving services with the different organizations. They became partners in that mobile team. They became partners in the stabilization center. They became partners in the integrative process of trying to get people into services more efficiently and effectively. So it was for us. It was a real good process to use the appreciative inquiry process. There's also World Cafe that you can use, and there's others, but that was the appreciative inquiry was the one that worked for us.
Okay, if people want to know more about that, they can call you and you'll help them get started.
Yes, I will.
Okay. I want to get to now a more generic question, which has to do with, you know, you both kind of talked about the variety of access and engagement initiatives that you've undertaken. Renee, can you talk a little bit about in working with families and you know, parents and children, for our listeners who are in that business, what was sort of one of the challenges that you experienced or that you've overcome at that initial sort of encounter? You know, when a family comes in, involved, of course, there may be a lot of static, a lot of confusion, a lot of fear. So you mentioned the front desk that you've trained them, and I wondered if you could talk a little bit about how you handle that.
Right. So I want to say that was actually a big miss for us for a very long time. We always underestimated the importance of that first point of contact. And we also underestimated the importance of basic customer service training. So we're offering that throughout the entire agency. But being able to give our administrative staff those crisis management tools like therapeutic crisis intervention, mental health first aid, and really teach them about the importance of being able to help a family through those first stages was really important. But, you know, I think more important for us in increasing our access and engagement has been the learning around meeting people where they're at. And so I don't want to overstate the obvious, but really integration in schools and primary care has been a huge part of what's given us access to so many more children and really reduce the stigma that parents are feeling so that they're not always coming to a satellite, a facility, or a crisis service area when they're in crisis, but they're engaging in a familiar environment. So I would say between meeting people where they're at, either in their primary care setting, where we're co-located in many, or in their school setting, and also really making sure that the frontline staff is prepared and that the attitude that the clinicians have and the supervisors have is just an open arms, we're all in this together type of mentality has really reshaped the culture of that environment and increased our engagement.
Well, Renee, you also mentioned something along those lines having to do with, you know, that tension between having to get a lot of assessments done and getting a lot of a lot of forms filled out, and of course, the need to really engage well with the person served. And you use the expression that your therapist stepped up. And I just wondered if you could elaborate on that. What is it that you did to get them there, and in terms of training, and what is it that they're doing specifically that kind of manages that problem?
Right. So we have family advocates located in several of our clinics that can really spend time with families that are really struggling with the paperwork or the processes or other referrals. So creating that position was a meaningful step forward, but also giving clinicians the time. I mean, we're so driven to make sure that every minute possible is a billable moment. We got very realistic about how much time clinicians need to be able to do the work that they need to do. So they have a little bit more time. We've also hired nurses to help with the healthcare screenings, so that takes a little bit of time away from what our medical staff was doing in the outpatient clinics and gives them a little bit more time around the more person-centered conversation and facilitating with all of the paperwork and all of the logistics that has to be done.
Okay, thanks for that. Just one other thing there. In terms of, usually clinics have, I think it's 3 sessions within which to complete all the assessments.
Yes.
Right, and you said that you've sort of come to a more realistic place around what it takes to really engage well. So, are you kind of saying that if a clinician is working with a family that is very sort of disrupted, that they may take more time than those 3 sessions to complete all the assessments?
They can if they absolutely need to, but I can say that we've spent a lot more time training the clinicians to be able to make sure that people who are presenting in a more complex way are walking out the door with something. Telling someone that they have to come 3 times before they're going to get anything out of it is definitely engagement killer. So
yeah.
We've blended in some strategies to make sure that we are listening and offering tools from the very first session that people are walking in the door with also, so that they, and as I mentioned a little bit earlier, the rate of us being able to retain people from going through that intake process, which used to be grueling and arduous and people didn't feel like they got anything, to getting them to engage in therapy is very, very high, between 96 and 97%.
So for our audience, I guess somewhere in that initial process, the clinician needs to think about what's going to make a difference for this person as when they leave here, and can we give them something to leave with?
Exactly, and lots of warm handoffs. So if we feel like we have another system that would be able to give them the support they need, they might need home and community-based services, they might need 24-hour crisis response services. We make sure that those are warm handoffs. So either the clinician is offering to make the phone call in the office with the family, or we're asking for assistance from a family advocate, or now we can even ask our front office staff to help with that.
Great. Thank you. Steve, I want to get back to you for a minute around the trauma-informed perspective that you've adopted. And I'm sure, Renee, you also have that in your services. Steve, though, what I was wondering is, what did you mean by environmental design? If you could kind of talk about an example of an environment that feels safe, what would that consist of?
Well, that's easy. Many of the folks out there, whether they have clinics or services, back in the day, and sometimes still today, people walk into a very sterile room, if it's a clinic or an emergency department, and the chairs are plastic, the lighting is very fluorescent, very bright. Just not a conducive environment to feeling comfortable when you walk into it. And if you walk into any of our respites, you're walking into what looks like a bed and breakfast. So it's just a more comfortable environment, but also being mindful of the people that are coming in through the door and asking the questions, do they feel safe? Because there are people that have been in environments that are triggers for them if they've been traumatized in those different environments. And what can we do to make it feel safe for you? But, you know, there really is a difference between walking into and I've been through into new emergency departments across the country, as well as new clinic services or different services in the communities that are very comfortable and very well lit, and better furniture is in there, and better information is on the walls. They're decorated. They're not the National Geographic from 1968 sitting on the table. Everything's updated and fresh. It makes a difference. It makes a difference for people. But really asking the question is, do they feel safe in that environment? What can we do to make the environment feel safe?
What this is to both of you around this issue of safety, because I think that safety is such an important part of people's coming back. That if you don't sort of give them that message in the very first minutes of their coming into services, as you said, Steve, that there's a very big likelihood that something will re-trigger and they won't come back. So, for both of you, how did you translate that safety issue in terms of the interpersonal aspects of services? So we just sort of did a little bit about the environment. How were your staff trained, and what did you do to raise the consciousness of your staff around this issue of safety? And Renee, if you could take that first, and then
Sure.
I'd like to hear from Steve.
So I want to back the question up a little bit to say that I don't think my staff felt safe for a very, very long time. And I can't say that all of them do at all times right now, but if they didn't feel safe, I can't imagine how they would make the people we were serving feel safe. So we actually took the step to get those life alert style buttons for everyone. Unfortunately, following an incident where even with the best practices that we had with the placement of furniture in an office and just every safety precaution we thought we could take already in place, we still had a very concerning safety incident. So we heard our therapist loud and clear saying, I'm scared, I don't always feel safe doing this work, and took steps to protect them to move that needle. So for me, it started with making sure the physical environment was safe and the perspective of the staff themselves was that of a safe place. In terms of working with families, we do safety planning with pretty much everyone that comes in the door, especially the folks that are considered high risk, meet that criteria. And so this phone call probably isn't long enough to go through the list of strategies that we deploy to try to impart safety on families in terms of phone call check-ins that we make if they're going to miss an appointment, phone calls to prepare them for an appointment, all sorts of actual tools and strategies, because when a parent is coming to you with fear, a safety fear that their child is going to kill themselves, the world pretty much stops spinning on its axis. So we do everything we can to give them evidence-based tools. We give out for free medication lock boxes to families where that's a safety concern. We make ourselves available. We make sure that they know how to access a strong behavioral health provider in our system 24 hours, 7 days a week. And we monitor them. And that's something else that goes right up to executive leadership is how our kids are doing in the high-risk list.
Steve, how about you in terms of getting your staff? Now, I know that, your staff, their sort of is what you called it is the special sauce is their lived experience. But beyond that, what did you do to prepare your staff and to raise the consciousness of your staff around this issue of safety in the relationship?
Yeah, we've always been focused on trauma-informed practices before we even knew what they were called, because we knew that people had been marginalized in many settings, and to not feel safe, such as someone feeling suicidal, being afraid to tell their therapist that they're suicidal, with fear of being forced into an emergency room or a hospital setting or a medication increase or anything like that. So we've changed language. We worked with National Council to actually develop a train-the-trainer module on trauma-informed practices, and something we did a little over a year ago, a little over a year ago, that really focuses on language and focuses on that engagement and building that relationship and, smiling instead of saying, "Oh crap, you're back here again." That there's just so much that you can do with the engagement to make someone feel comfortable. Also sharing, we train our staff that we don't get right to the paperwork. We ask, what happened to you? What brought you here? How can we help you right now in this moment? And then explaining in a transparent way, we're going to have to do some documentation, and we'll explain why we have to do the documentation when we get to it. But right now, we want to make you comfortable. We want to help you feel comfortable while you're here. So that's really important. But we do a lot of training. We have a certified peer specialist training in New York State that we've put a lot of that trauma-informed practice into. We are part of Relias Learning, where we do a lot of trauma-informed training in there as well. We do motivational interviewing for all of our staff. They're all trained in applied suicide intervention strategies, so that they can pretty much deal with a lot of different engagements that they come face to face with. And again, that the thing that works really well is when one of my staff can say, just if I can share this with you or get your permission, I've been through an experience similar to this, or I've been diagnosed with whatever. And it helps people feel more comfortable when they know they're not alone. So, we have that added value in helping people feel, safer in our environments.
When you mentioned language, and I think that that's something that, in the field, we tend to, rely so much on jargon and labels. Can you give one or two examples of language that you've stopped using and what you've replaced it with?
Yeah, for when they come to our Rose House, they don't do an intake and we don't do an assessment. They do a guest registration. So we actually treat it like a very important bed and breakfast stay for people. We don't call them patients, clients, or anything like that. They're a guest. And at the Stabilization Center, it's the same thing. They're guests there. They're not a patient or client. And the reason why we, really focused on that language and changing that, because you can always get into semantics and semantics arguments, and I've done that more than my share. But it's not an argument for us. It's just what we know we can control and do in our community and in our organization, and people feel better when they hear those terms. They feel more important. Now, contraindicating that would be when I was in Iowa, there was an organization that called everyone clients. And the question they said to me was, well, how do you feel when you go to a high-priced lawyer and sit in their office, which is very nice usually, and they call you a client? Do you feel important? And I said, well, yeah. So it's taking it in the context of the service, I think. And I think for too long we've kind of marginalized people to be clients or patients. And I've heard many people in the service industry say, these are my people. These are my clients. These are my taking ownership of somebody as if they have to take care of them, and we don't do that. We promote independence. We promote self-determination. We don't own anybody. We make sure that if they're a guest, that they're going to treat the residents or the service that they're in with us as much, as well as they would any other person's home, and they're going to respect. And so respect becomes a very big, important part of this.
In terms of, the other community providers you work with, one of the things that I've heard people say is that, I can do all of this in my setting, but then once I refer somebody to another provider for another service, it's all bets are off. I wondered, in terms of your philosophies, both you and Renee, how have you sort of communicated or tried to influence the approaches of your provider neighbors?
So that's
or have you?
Yes, that's one of the most fun parts of my job, actually, is we have engaged our partners at different levels. So in one group that I'm thinking of right now, it's a blend of some providers and government representatives. And we started talking specifically about children who are not doing well in the community. And our approach to that was, we're all grown-ups at the table, we all do good work, and we all make mistakes. And this is the opportunity to convene and talk about specific children, specific families, and what we need to do better, either as an individual provider or a system providing services in a specific community. So out of that has come some really wonderful improvement opportunities. And I can say that it was my idea to start this work, and the very first problem that came up was one within my own agency. So it was a little, I try not to be completely embarrassed by that, but it was a great opportunity for us to model what we were looking for in this group. And it's become a steering committee, and we've replicated that in two other ways with different groups of people, where we just really talk about what's going wrong. It could be about a system issue, about making referrals, and we call this removing barriers to care. So the point is that the child or family or adult gets what they need when they need it, no matter what our system, no matter what obstacles our individual programs might be putting up. And then we have to go back and reflect on what obstacles we've been creating for people and try to remove them.
So for us,
Yeah.
the fortunate thing has been many people are starting to change their language, and they're starting to use the term guest in different services. They're starting to use kinder language, more respectful language in the services they use. So it is something that's slowly caught on. But one of the most important questions I often ask is, how do you want your loved one to be treated, and what do you want to hear? And so it gets people to think about how they treat the people they serve, and hopefully changes their paradigm of service.
I'm just wondering, have you experienced any obstacles? If you're getting Medicaid reimbursement, you have to write notes, right, for every session, for every service that you provide. I'm wondering, have you gotten any pushback around, using non-pathologizing language in?
Yeah. So you do have to write your Medicaid notes, but it doesn't mean you have to speak the language of the person you're serving. So we've hit that many times across the country, had that conversation, because people said, I can't just put a guest in a note because they're not going to accept that under Medicaid or whatever. And so it's really about, what you say and what you write can be what you need to write for a Medicaid note. And the other thing, too, I think it's important, and we started doing this in Ulster County, where the clinicians were turning the book on people and saying, these are the notes I have to write today. Do you understand them, and are they accurate? So getting input from the person you serve, too, is also a big factor in building better engagement.
I'm wondering, do either of you use, concurrent documentation as an engagement strategy where, because what I found is that it builds a lot of trust when, and it also gives the client, the person served, a voice. I wondered if any of you have used that successfully, where the actual note is being written in collaboration with the individual in the session.
Right. So it used to be called for us concurrent documentation, but now we call it collaborative documentation for exactly that reason. And our assessments that we do are also collaborative assessments, so that they're actively participating and viewing what's going into the EHR. So yes, we're using collaborative documentation.
We've been using that since I started.
Okay. And are you getting any pushback from your clinicians on doing that?
It depends on who they are. We're years into it now, so I never hear about a problem with collaborative documentation. But moving into that space, particularly with our medical providers, at times has been a challenge. But so there's been some attrition around it. But we've come to a place now where that's just the expectation. And if you're a new hire into the agency, you know nothing other than that, so it's much easier.
Okay, I'm going to ask each of you to answer this question, and then we're going to go to our audience for their questions. So if you were to do a pitch, you're going to go to a managed care organization or some other payer, and make a pitch around your efforts at engaging folks and creating environments of safety and so on. Could you both sort of in a few sentences sort of formulate, initially how you would portray your innovations in engagement and access to a payer? So, Steve, why don't you go first?
It would just be we definitely discuss our outcomes and the return on investment, and we have that data that shows that there not only are there savings, and that's not why we did this, but not only are there savings, but there's better outcomes as far as overall wellness, self-determination, empowerment, independence, employment. So it does make a difference in people utilizing less services and providing, and moving more towards an independent life.
Renee, in terms of families and children, how would you make that pitch?
So I would, very similarly to Stephen, I would point to the data that we're able to provide the right service in the right amounts, in the right places to people, that they're engaging with the service, but that they're also disengaging with the service at the right time. And that's been just as hard as engaging folks at the right time. So knowing when to say when, knowing when treatment is complete. And for the organization, it's also very important for us to know how long we will be in a treatment relationship and when to end the treatment relationship. So I think that we present a pretty strong value proposition to an MCO in that we've spent years understanding our own work, measuring our own work, proving ourselves, and now because we're so strong in our data analytics, we can move the needle whenever we want to. Children with homicidal ideation, suicidal ideation, whatever it is, we know exactly where they are, who they are, and how they're responding to treatment. And if they're not, we can move the needle really quickly on them. So that's it's all about the data.
Okay, I just personally want to thank you both for sharing your expertise and for giving our audience some really good information around how to transform their services into ones that are fully engaging and fully accessible. And Daniela, I move it back to you now, and I know I have to move the ball, right?
Yes, please.
Okay, so I'm looking at the screen. I don't know that I'm sure about how to do this.
You got it. I got it. We're all good.
Got it. Great. Thank you.
All right. So I do want to also say thank you to Steve and Renee and to Eve for facilitating that discussion. Before we get into questions, actually, before I get into what I do before I get into questions, I just want to remind people that they do have the opportunity to type in your questions using the chat box. We did have a couple questions coming in during the presentation. And just a reminder that the third and final webinar in our Solutions That Work series is on November 29th at noon, and the focus of that webinar will be on the integration of behavioral and primary health care. And with that, I am going to jump into some questions for our panelists. These are basically, actually, Renee and Steve, these are basically questions that both of you can answer. They're not specific to either of you. So what data do you collect to support your access and engagement outcomes?
So we monitor admission rates that I referenced. We monitor follow-up on appointments. Of course, we monitor missed appointments. We monitor length of stay, length of treatment, I should say, so that discharge is at the right time. There are so many variables, but those are sort of the high flyers.
And just to add to that, we use 8 dimensions of wellness. That's a monitoring that we work with to measure their overall quality of life. We do measure the 7-day, the 30-day callbacks, and we have another program that we use where we don't use where we discharge people. My staff actually bring people home from a discharge and hospitalization, and what we use there is a 24-hour monitoring system, and then a 7-day callback, 30-day callback, 6-month callback to see how they're doing. And then they also have access to us, so we're constantly monitoring and measuring that.
We also measure service satisfaction, of course.
Yeah.
Excellent. All right. Next question. Can you both speak to any barriers or challenges that arose in your organizations in relation to improving access and engagement, and how did you overcome those?
For us, it's been a culture issue and a culture change. And in order to effect the changes that we wanted to see in access and engagement, or really any change, but particularly here, we really had to engage the frontline clinicians in solving the problems. And we really changed how we address quality process improvement through a steering committee model, and we engage those clinicians in helping us solve those problems. So we've, like anyone on the call will acknowledge that if the people doing the work are part of the solution around improving engagement, improving access, then they can come up with the best solutions.
I think for us it was figuring out how to capture the data, because there's so many variables in data that you could be measuring, but you don't want to inundate your staff with that. And so that was a big part of it for us. Our culture was already there as far as understanding what our role is. So more management.
Okay. Great, thank you. And a question now about open access. Have you ever experienced bottlenecking during open access?
I actually asked my clinic director a similar question, and they hadn't. They closely monitor the wait time during open access, and there are some clinics that have a longer wait time. The average is 30 minutes, but it's more related to geography. If it's one of our rural clinics, the wait time can be longer because there are fewer clinicians. But generally in our more populated areas, we haven't yet experienced that.
Yeah, we've had some access issues into the Rose houses because we only have, between 5 and 6 beds in each of the houses.
Sure.
But we have mobile staff too that will come out to visit you if you're heading towards crisis. And we have a 24-hour warm line that they can just talk them through. We found that these really work to keep people in a better place until they have access to the house.
We do experience a lot of barriers to getting our kids seen by a psychiatrist, and that's probably not very surprising. But the way we manage that is by triaging. We set priorities.
All right, very good. So we actually just got a bunch of questions all at the same time, so I'm going to try to get to all of them. What is your protocol in re-engaging those folks who are high risk?
We are all over them. I don't know how else to say it. We have very high monitoring, and this has really come from learnings along the way. We make sure that we're scheduling them at times that we're pretty sure they can be seen. We are making sure that we're calling them to remind them about the appointment. If they miss an appointment, we're making sure that they get a personal phone call and that they are given priority and being seen again right away. If the clinician is going on vacation or is out, there's always a backup process so that someone else is monitoring that high-risk list and that there aren't any misses on that. And that also gets monitored by a supervisor. So there's a high amount of attention that goes into the high-risk children. And I can say that at a time when we saw suicide attempts spiking along with the national average, which happened really right around the time that 13 Reasons Why came out on Netflix. I'm just referencing that as a point in time. We have since seen, with this implementation of very high engagement with those families, we've seen a very sharp decrease in those attempts. So it seems to, with other factors, I'm sure it seems to be paying off.
So I can say in our transition of care model where we bring people home from their hospitalizations, we partnered with a clinic provider that also does a follow-up. So they're getting follow-up from our organizations and the clinic organization. And then we also keep track of their appointments and their medication. When that's coming up, we give them a phone call. Do you need help getting your meds? And it's not just that. It's also, again, the relationship. The relationship that you create with the people you serve is so important. And building that trust is important because we find that they start to call us or utilize our services prior to using the traditional crisis services that they've been using. So it does kind of break that cycle.
I also want to mention that because we're partnered with so many crisis services, my next hope is that those folks, for example, the ones that work in the Crisis Stabilization Center, will be able to actually access our outpatient clinic schedules themselves during off hours and work through our central scheduling system to schedule that follow-up appointment so that someone's not leaving an emergency department or a crisis stabilization center with a phone number to call, but they're leaving with an appointment.
That would be awesome. Steve, this question is for you because you mentioned the warm line. What is the title of the personnel who are working on the warm line? What's their title?
They're peer specialists.
Okay.
Yep.
Okay, cool. And are surveys being provided to the parent or caregivers at Astor? And if so, do you think this is a good way to track feedback? Do you utilize the feedback to do any program improvements?
So, yes, they are given to children. We have a children's version and there's a parent's version, and we utilize both. We just launched a really robust client satisfaction survey process where we use tablets so it can be done in real time. And in our first run, we had about 1,300 responses, so we felt like we had a good sample size. And that all becomes actionable. So that data gets reported up into myself as the COO, the executive cabinet, and that all becomes actionable work. In our residential treatment facility, I've actually asked our intake worker to make personal phone calls every 60 days to all of the families of the children who are in care with us, because I feel like that level of care is just so incredibly important, and those kids are it's so important to move them out of the system as fast as possible that we do personal phone calls to gauge their satisfaction, and we make sure that it's not the person providing the service. It's always the intake coordinator who does that.
All right, and I've got one last question for you guys. How do you try to engage those individuals who are chronic no-shows or cancellations, but express a desire to continue services when options such as walk-in hours, flexible scheduling, and things like that haven't worked?
We're really lucky in that the outpatient environment is only one of our systems, our service systems. We have a lot of different opportunities to try to engage people. If nothing else is working, I'll refer to our ECCSI program, and that's where one of our staff will go to the family's house and talk to them about what would work in any way, shape, or form. what would work. And that sometimes involves the creation of a new way to deliver a service to a family. But especially if a child is high risk, we will do everything we can to get the services they need to them.
So we provide a lot of education around, and it's motivational education around why they don't go to the service. And we ask the question is, why aren't they following up? And it could be a social determinant issue, or it could be that they just don't feel comfortable in that environment. And so we will work with them to find a provider or therapist or somebody that they do feel comfortable with.
All right. So I just want to, again, thank you, Steve and Renee and Eve. Thanks for getting those questions together and facilitating that discussion. We are sadly out of time. So thanks to all of our participants, and have a wonderful day, folks.
Thank you.
Thank you.